Thank you, everyone, and welcome. We'll get started. My name is Barbara Lindsay. I'm a veterinary neurologist, and I'm in Dallas, Texas. And I will be joined by longtime family friend and mentor, Kirsty Sexel, who's a veterinary behavioral specialist based in Sydney, Australia. We have no financial disclosures, but we will be discussing some unlabeled, unapproved meds for use in dogs. And before I go on, can everyone hear me okay? Thumbs up? Okay, sweet. All right, let's talk about neurologists. What do we do? What do we like? We localize lesions, we kind of find where the problem is, we cut it out, we sample it, we give steroids when we find inflammation. We like things we can identify, right? Like the meat and potatoes of medicine. And then over the last few years, I've started to realize that I don't feel comfortable in behavioral medicine. And I don't think I'm alone. In fact, less than half of veterinarians don't feel comfortable with behavioral medicine. And now I've literally completed a residency specialized in this squishy organ, and I still don't feel comfortable in behavioral medicine. And I don't think it's just me. I don't think it's the hospital. I think this is a systemic challenge in veterinary neurology, but in human neurology too. Okay, so often we are seeing patients for a behavior change. This is one of them. And we have to figure out, is it neurological or behavioral? And let's have a hands up. Who has a behavioral specialist that you can walk down the hall to and talk to them? I'm seeing maybe 4 or 5 hands. Who has someone that they could pick up the phone and that they would answer? There's a couple, right? We don't have that luxury a lot of the time. So we're going to talk about why our two specialties are so separate. We're going to talk about some abnormal repetitive behaviors, pain and neuropsychiatry, and then we'll touch on canine cognitive dysfunction. Okay, the breakup story. Until the 20th century, neuropsychiatry was a unified branch of medicine. And I'm going to talk a little bit about history, and because we're under the branch of Western medicine, I'm just going to focus on the West here. But where do I start? How could I start? 10,000 years, 10,000 cultures, but I had to choose one. So I'm going to go with this guy, Melampus. He was possibly the first seer psychiatrist, priest-psychiatrist, described in Homer's Odyssey. He cured Iphicluses of his impotence issues by talking about his histories. And he also cured an entire island of women who had some madness. Maybe the two events were linked, I don't know. But if you wonder where that snake symbol comes from in medicine, the snake with the sword, it's this guy. He happened to rescue 2 snakes, and they gave him the gift of speaking to animals. So I think this is the OG Dr. Dolittle. I don't have time to talk about another 2,500 years, so let's fast forward to the Middle Ages. This is an excerpt from the Compendium of Medicine. It was 7 volumes, and it took all the knowledge that they knew at that time from the Greeks and Hippocrates, Arab physicians, the Schola Medica, which was like the medical school of medieval times in Italy. And the reason it's important is because it talks about mental disorders, irrational phobias, hallucinations. And it's this book, along with the Rosa Medicinae, which formed the basis for medicine for the next 400 years. Now, what was medicine at that time? It's this kind of combo of demonism, right? The devil's in your head, and humors. So black bile and phlegm and too much of the this or that. And we really see that the church is the center of medicine. As I mentioned, that Schola Medica was actually a monastery initially. So this is Friar Geoffrey in 1409. He goes to present a sermon, and on the way, he notices a bunch of folks are harassing this mentally ill man, and he decides this is unacceptable. 1 year later, he opened the Hospital of Lunatics, Insane and Innocents in Valencia, which is probably the first Western mental asylum. And we can see here the connection between church and mental illness. This is everyday life in Venice. And you can see up here, top right corner, a priest is doing some miraculous work, healing a man who has been possessed by a demon. And my personal favorite is the little Maltese on the way to work with his owner. And perhaps this work really epitomizes the connection between church and the psyche. This is an altar at St. Anthony's Monastery. St. Anthony's disease is a disease of ergotism or rye toxicity. You get terrible vasculitis. Your fingers, your toes, they hurt, but you also get hallucinations. So this painting shows not only the pain aspect of mental disease, but that psychological component. But across Europe at this time, we get a wave of new thinking. It's called the Renaissance, really changing what we thought about a whole bunch of things, including health and medicine. And we get new inventions, the printing press, the telescope, the clock. And we're starting to get away from the idea that it's like demons in your head, and maybe it's because more of something going on in your body. And for example, this picture of melancholy shows that, at that time, they thought it was because of too much black bile. And finally, we enter the Age of Enlightenment. So the scientific era begins. And I chose this painting because the man in the center there is demonstrating a vacuum pump. Air is visible, so in order to demonstrate it, he's put a bird inside it. He's about to pump out the air, kill the bird. And I just love this dichotomy because the girls are terrified. They know what's going to happen. And it's this interplay between like science and morality. And perhaps the gentleman down the bottom with that resolve of, we got to do this. We got to do the experiment. It's just not good for the bird. So with that time, we get the invention of the microscope, and we see now the powerhouse figures of neurology, right? Like Mr. Willis, as of Circle of Willis, termed the word neurology back in the 1600s. Jean-Martin Charcot. We have Cajal, who developed the word neuron as the basic sort of structure, basic unit of the nervous system. And it would have been really easy for psychiatry at that time to just wash away, right? Like, we have all these neurologists learning all these new things, but they clung on. We had the term psychiatry coined rather late in the 1800s. And then Greisinger wrote a textbook, Mental Pathology and Therapeutics. It sounds modern. It sounds something like new. You could buy it right now. He tried to make a journal that combined psychiatry and neurology. Didn't go well. After a couple editions, it was out. And then how could I forget this guy, Sigmund Freud? He's kind of like just so ingrained in our sort of social, psychology. We forget sometimes that Freud was actually a neuropathologist before he was a psychologist. You think about it all the time, like Freudian slip. Please tell me I'm not the only one in the room who's done a little intervertebral disc disease with a family, right? And of course, by the 1900s, there was no going back. Sir Charles Sherrington coined the term synapse, and we now knew that diseases like multiple sclerosis, cerebrovascular disease, they had a neurological origin, right? Like, is there any point for psychology? It's all kind of fluffy. We found things on the microscope. Well, let's hail the chemical revolution. We had a bunch of scientists post-World War II, a lot of research, and they were finding these new antidepressant drugs. And in fact, the first antipsychotic medication, chlorpromazine, and then imipramine. And this is where psychiatry really got their foot in the door in conventional Western medicine. This advertisement over on this side was published in the American Medical Association, like, free the housewife. And back in the good old days, like, can I be prescribed this, please? So this is now a $20 billion global market. If you look to your left and your right, 1 in 6 of you is on drugs, psychotropic medications, but let's face it, it's veterinary medicine, so it's probably double that. And so what do we see in veterinary medicine? We see 2 colleges. We have neurology was recognized as a specialty by ACVIM in 1974. Around the same time, we have the Veterinary Ethology Society, later renamed to the Veterinary Behavior Society. And in 1993, the American College of Veterinary Behavior was approved. And we see differences still in terminology. So behavioral medicine uses disease sign, so anxiety, phobias, whereas neurology, we love etiology, right? Meningoencephalitis, cortical malformation syndrome. And there's really little to no cross-training between neurology and behavior. I think behaviorists have to spend about 2 weeks with neurology. Like 2 weeks, you kidding me? That's enough time to learn how to know this stuff? No way. Neurology spends 0 weeks with behavior medicine, none. Traditionally, tail chasing has sat quite firmly in the veterinary behavioral camp. But recently, we've started to identify genes that are shared between human OCD and dogs with tail chasing. Where was the problem? It was on these dendritic spines, these little protrusions where, one axon of a neuron talks to another. Shadow chasing. This isn't a cavalier, but it's a patient I saw with shadow chasing. But they did a study with cavaliers. They found that positron emission CT, these cavies had higher dopamine transport ratios. They treated them with clomipramine. Their behavior got better. And when they repeated scanning, the dopamine transport ratios got better. We'll see here in Dobermans with compulsive disorder. Summarize a few studies for you, but basically in these compulsive disorder Dobermans, they had abnormalities in chromosomes associated with glutamate function. They had some associations with chromosomes that in humans increase your risk of schizophrenia. Serotonin receptor genes, and they also found structural differences on MRI, which were worse if the compulsive disorder was worse. So I ask you this. If a disease causing a behavioral anomaly is found to have a structural localizable lesion or a genetic aberration, would this fall under the management of a neurologist? I don't know. But what I do know is we see these cases, right? And it's us as neurologists that play a role in diagnosing them or excluding other diseases, and perhaps even starting initial therapy. So let's talk about some of these. We'll start with abnormal repetitive behavior. These are stereotypies or compulsive disorders that are repetitive. And we tend to group them all together because they appear purposeless or out of context. And some examples, flank sucking, fly biting, over grooming, tail chasing. And we often compare them to humans with OCD. Now, I can't ask this dog if it's having obsessive emotions, so we'll prefer to use the terms compulsive disorder or abnormal repetitive behavior. We tend to see these ARBs having a bimodal age distribution, so they'll either start in the very young dogs, so teenagey kind of dogs, or in the elderly, which may be associated with cognitive dysfunction. We know there are some breed associations. You may have seen things like Staffordshires doing their circling or tail chasing, Border Collies with shadow chasing, and there can be environmental influences. One study looked at it was more likely to have this behavior if you're in a single dog household or a first-time dog owner. And I think there's going to be some unintentional reinforcement of these behaviors. This video has some sound. This was happening for hours every time the owner went to bed. And one study looked at dogs who were tail chasing, 400 videos on YouTube. About half of the videos, the owners were laughing or encouraging the behavior. And when they looked at these videos, the ones where the dogs wouldn't stop circling were labeled as funnier and had higher views on YouTube. But I think it's important to recognize that just because it's an ARB doesn't mean it's behavioral by definition. This was a bulldog I saw for these episodes of just kind of seeming out of it. He would like move his head side to side. The owner couldn't really distract him out of it. A little bit more history. The dog had chronic chin dermatitis. Like, yeah, it's an ARB, but he's literally just scratching his face. So it's really important that we don't just sort of see an RB and quickly say like, oh, it's behavioral. We need to investigate underlying causes. So this is a video of Buddy. He's a just over 1-year-old Shiba Inu. You can see up the top here, that's labeled as around 9:30 in the morning. But he presented to me for vision impairment for 3 months, and the owner's not really sure when it started. No improvement with prednisone. I'm not sure why, but the primary care veterinarian thought it was very wise that they saw an ophthalmologist for this behavior. So he had a normal exam. Came to me for a neuro consult, and neurophysical exams were normal. And you can see on the bottom video on the right, this is 9:30 at night. So this is happening all throughout the day. And imagine living with this. Like you're trying to go to sleep and it's just, this dog just does not shut up. So minimum database, normal, bile acids, normal, brain MRI, CSF was all normal. Going back to the history, I must admit, sometimes the RDVM's write in handwriting and I can't read it and I don't try that hard. But I did, so I went back. At the early vaccines, he appeared anxious, fearful, and was noted to be circling at that time. By 7 months or 4 months, he had bitten someone. 7 months, he'd been to a dermatologist for atopy. And at 8 months, when he went to the vet for something else, he was like fearful and trembling. So this was a diagnosis of a compulsive disorder. And once again, videos aren't enough. We need to do a neuro exam. We need to rule out forebrain disease. But depending on where you are, like I'm in Dallas, it's a really big city, but it's still going to take a few months for me to get a behavioral consult. So it's often up to us to start something. So let's talk about treatment. Like human OCD, medications that inhibit serotonin reuptake are the most effective for treatments of ARBs in dogs and cats. So for the most part, we'll talk about clomipramine and fluoxetine. So this is a serotonergic synapse. So we have our presynaptic and postsynaptic neuron, and we have serotonin, 5-HT, which is packaged in little vesicles, and then it's released across the membrane and goes to serotonin receptors. But in order to kind of clear the serotonin from that space, we have a serotonin reuptake transporter, okay, the SERT. This is going to be the target for many of our psychotropic medications. Oh, so it's actually genetic differences in this guy that can determine whether or not you're predisposed to depression or anxiety. Fun fact. So TCAs, tricyclic antidepressants, the most common one you probably think of is clomipramine. And it'll inhibit that SERT transporter, but it also will inhibit reuptake of norepinephrine, and as well as having histamine blocking activity, muscarinic, alpha-1 adrenergic blocking. It is FDA approved for separation anxiety in dogs, but it's with behavioral modification. It's not designed to be used alone. For SSRIs, the most common one you know of is fluoxetine. Highly selective blockade of serotonin reuptake transport. I put some doses here. These are also in your reference notes, so if you can't snap a picture in time, they're on there. This is off-label use, and these drugs can lower thyroid levels, but rarely result in hypothyroidism, and we'll talk about behavior modification as well. So in general with ARBs, really important to investigate for underlying causes, whether that be neuro, GI, derm, pain, and perhaps even sensory impairment. One paper looked at fly biting, and some of the dogs with the most severe fly biting episodes were those that were deaf. This was a patient, I saw a young Great Dane who was shockingly deaf. It is more likely in dogs who have increased inattention, hyperactivity, aggressive, as I mentioned, certain breeds of dogs. So let's have a little talk about pain and some of these syndromes. This was a cat that my colleague had seen who, I think when the cat came to us, it had had a tail amputation due to self-trauma from this. But pain is a differential diagnosis for almost any behavioral change. This was a dog I had seen for these episodes of just staring into space. It wouldn't really respond to the owner. And of course, it comes to neurology because it must be neurological. Neurophysical exams were normal, so I scanned the brain and I actually found this large soft palate mass. Now, we happened to see it on intubation, but I figured the best way to image it was just to do the MRI anyways. And we sampled it. It was obviously very nasty carcinoma, but just an example of how pain can manifest in different ways. For neuropathic pain, it is a clinical description. It's technically not a diagnosis, so ideally we would find the underlying lesion or the disease. But this is really common in human medicine. So about half of people with a spinal cord injury will develop neuropathic pain. And then we'll see it in other diseases, like, for instance, 10% of humans who have had a stroke will develop neuropathic pain. We're starting to recognize it, obviously, in veterinary medicine with tail mutilation, feline oral pain syndromes, hyperesthesia, syringomyelia, etc. But what I want to do is introduce this concept of numbers needed to treat. NNT is a measure, a metric they use in a lot of human studies. And basically it says, how many people do I need to give a drug to in order for one person to have a 50% reduction in pain, okay? And there was this study, 2015, the Neuropathic Pain Special Interest Group did this big systematic review, and they talked about, hey, these are our first line medicines, right? Now, gabapentin in our hospital, it's like Oprah and candy. So let's think about that. NNT for pre-GABA, 7. It means you have to treat 7 people in order for one person to get a benefit for their neuropathic pain. Serotonin, norepi, reuptake inhibitors, NNT of 6. Tricyclics, close to 4. They didn't even find evidence for MDMA antagonists. And this metric, it kind of changed how I thought about neuropathic pain. The first medicine I choose probably isn't going to work. Statistically, it won't in people. It means that I need to either think about combos of medicines or maybe medicines that I don't feel very comfortable with as a neurologist. So let's talk about amitriptyline. As I mentioned, it's a TCA. It inhibits reuptake of serotonin and norepi, and it attenuates neuropathic pain by sort of affecting the spinal cord inputs, activating those alpha-1 and alpha-2 adrenergic receptors, and it also has histamine blocking activity. It does have some side effects. So in people, they talk about dry mouth, which is kind of what I'm experiencing right now. Blurry vision. It can cause urinary retention. We have to be a little cautious in epileptic patients. Be cautious if you have a patient with glaucoma because it can result in meiosis. I've listed some doses there. Really importantly, you need to wait at least 3 weeks to know if it's working. So when we're thinking about pain, we need to investigate, is there an underlying reason why this behavior is happening? Could it be pain related? And if you're treating neuropathic pain, success may require multiple trials and combination therapy. So now I want to introduce Kirsty to the stage and we'll go through some cases.
Thank you. Now you get to hear a real Australian accent, not one that's been
Americanized.
so. No, I worked at UPenn for a while and I found that I could talk to people one-on-one with my Australian accent, but if I got on the phone, nobody would understand me unless I went,
Hello, do I press the pound key now?
so I now know what a pound key is. So let me talk about Archie, and interestingly, most of the cases on reflection don't talk about any of the medications that Barbara's just talked to you about, but I am from Australia. I'm from the Antipodes, and we don't have all the medications you have, and sometimes we have medications you don't. For instance, trazodone is not available in Australia. We can get it. We can compound it, but it's pretty cheap here. It's about $4 to $5 a tablet in Australia. And yeah, wow, and you guys hand it out like candy, so do our vets. And I keep saying to them, there are better options that won't lead clients dry. So Archie came to me a long time ago, probably very early in my stages as a specialist. He's an 8-month-old male entire English Cocker Spaniel and he weighed 10 kilos. Sorry, I can't do pounds, just not in my bailiwick. We've been metric for a long time, so you'll have to do your own conversions. His presenting complaint to me was that he was circling. And when I saw him in the consult room, he spent the whole 3 hours doing this unless we distracted him. And you can imagine by the stage, the owner was getting pretty tired because living with a dog that circles all the time can be really hard. Interesting though, he didn't quite circle all the time. He was obtained at the age of 4 months from a breeder to join the other dog. The owner had a 12-year-old male neutered Cocker Spaniel and he really loved Cockers. And as a puppy, he was fearful of the outside world. He was freezing whenever he was taken outside, but extremely hyper in the home environment. The house training was really difficult. For me, that's always a red flag when I see a puppy that's difficult to house train, that there's something going on here. But he was always excited and moving around. And so whenever the owner went outside to reward him, she couldn't really reward him because he was like, oh no, I've got to do this, I've got to do this. However, about 7 months of age, the owner said, yep, he was okay. He's displayed the circling behaviour from the first day the owner brought him home. But like all breeders, oh, it doesn't happen in my breeding group. We've never seen this. Does that happen in America too? Like never in my life, okay? Right. So nowadays I actually try and get pedigrees from all my patients so I can actually track them back to see what's going on. I've yet to find the time to collate the information, but one of these days I'll get a resident who'll want to go through it. Anybody else know about that? You collect information and it just doesn't kind of get anywhere. But anyway, I'm working on it. Archie spins and runs around in circles at least 5 times a day on most days. So it wasn't all the time like it was in the consult room. It was intermittent. And he always did it counterclockwise, but he can be interrupted by loud noises. And he was observed to spin when he was kennelled. So when he was in the kennel, he did a lot of this. Now, for me, this is building up a picture that's probably very different from a neurologist's picture of what's going on. He was more likely to spin when he was excited or under stress. But the owner's not been able to identify any specific triggers for his spinning and doesn't know if he spins at home when no one's there. So he didn't have a camera. Because when I was doing this in the old days, you know, I proudly tell people I graduated last millennium. Think about that. You know, it's not that long ago. But, you know, last millennium, nobody had little phones and stuff and the video recorders. Somebody must be old enough to remember when somebody's nodding good. I'm glad I'm not the only one in the room. But people didn't have access to this stuff. So you had to go a lot on the history and what signs you saw. At home, he's more likely to spin outside near the back door and inside in the front room and at the back door. So again, there's a picture building up what's happening with him. On leash, Archie will spin if the owner stops to speak for someone, so all the walks had to be kept going. And Archie's circling has become less intense and is sometimes substituted with pacing over time. And that's because by the time he got to B, he'd already been put on some psychotropic medications. He went to puppy training, but he was very excitable in training, and the owner tried to take him to an adult class, but he was easily distracted at training, so they didn't actually get very far. So the diagnosis I made at this time was obsessive compulsive disorder, and you know there's still a little bit of discussion in the behavioural world, and we've got another behaviourist in the room, so she might back me up on this, or maybe it only happens in Australia. But most of my patients are obsessing, even though I can't ask them. the behaviours they do, they will get up in the morning and they will go and stand at the window where they know the sun is going to come up and the reflection is going to be. That's very different from a compulsive behaviour where the dog doesn't anticipate this is what's going to happen, and they will walk around waiting and waiting. And for me, even though I can't ask them, to me that dog's obsessing, because you don't get up at 4 a.m. waiting for the sun to come up in that room unless you're obsessing about it, because the compulsion should be when the sun's already come up and you have to do it. But we can keep arguing the toss somewhere along the line. And an anxiety disorder, because I do think this dog was very anxious. And if you think about the history, there was a lot of times when he was increased in anxiety and in what I call frustration. And frustration is something that when I went through vet school, we weren't allowed to anthropomorphise anything. Whereas now in veterinary behaviour, I find for my clients, if I anthropomorphise, they get it better. They understand if they have some experience of that. But I think this dog was anxious. And of course, we had to think about neurological causes. He went to see a board-certified neurologist in Sydney. They did a whole pile of tests on him and could find nothing neurologically wrong with him. And unfortunately, Archie, we treated him. He was started by his local vet on clomipramine, and clomipramine is registered for dogs in Australia. Fluoxetine was, and then it wasn't. But at the time when I saw him, it wasn't registered. And at that stage, for a packet of 28 fluoxetine tablets, it cost the owner $100. So you can imagine that that's not the first medication that the local GP is going to put them on, because it's just too cost inhibitive. But by the time they come to see a specialist, they're kind of more willing to open their pocket, because they want a pocket book, you call it, don't you, to do that. So we treated him with fluoxetine. He improved, but his quality of life was such that we had to euthanize him after about 6 months. And people often think euthanasia is, not a good thing. But for me, this dog was suffering. His quality of life was not great, because running around in circles is not the way to live your life. But secondly, the quality of life of the owner was unbearable. He loved his dog to pieces, but this dog wasn't able to interact with him, wasn't able to do things. And so for me, euthanasia is sometimes a success for some of the cases that we see. My next case is Rodney, also known as Mr. Grumpy. That's what his owner called him. He's an 8-year-old male-neutered dachshund. In his household, he's got his little sister Rhonda, who they were related, and she's been spayed. There were no other pets. The owner was a veterinarian, and you know how good veterinarians are as owners, so you can already see where this is going to go. He was married. There was no children in the household. And Rodney came to see me about 6 months ago, so he was 7.5. He started showing behavioural... 6 months before he saw me, he started showing behavioural changes. You've taken the U out of behaviour. My goodness. Oh. She's an Aussie and she doesn't know how to spell behaviour. Oh. Okay, we'll let that slip. I'll see what other changes happen in my next lot of slides. He appeared depressed, not as eager to exercise. He walked slowly and didn't want to be sociable with other people or dogs. The owner, I only saw the male owner of the vet, commented that he was always shy of other dogs and scared of big dogs, and the behaviour had worsened over time. He talked about amitriptyline causing dry mouth. I'm on amitriptyline because I've got complex regional pain syndrome. I'm not in pain at all, and I think they call it a syndrome because they've got no flipping idea what causes it. That's what I come from. Because I don't have any of the signs except I can't move my hand properly and I get a dry mouth. But amitriptyline doesn't help in any way that I can see, but I'm back to see the pain specialist next week, so we'll see what happens. So the behaviour had worsened over time. He now appeared to want to go back to his bed rather than associate with the other dog. And he and his sister got on really well and did everything together, but now they didn't want to do this. He was not as playful as he had been. He did greet the owner and jump on him as normal when he came back from work. The owner described him as being in a blue funk. Now, that's not an expression we use in Australia, but the owner had lived in America, so I'm assuming it's an American expression that's in a blue funk. Basically, I think he's just depressed, that's what I call him, like he's in a blue funk. I had to get the owner to tell me where he got that from because it's not an Aussie expression. I've never heard it, no. Well, you can't spell behaviour, what would you know? So 4 months prior to seeing him, he'd had a full blood count, biochemistry and T4 performed, and the only abnormality noted was a slightly decreased T4. The owner considered giving him thyroxine, because he's a vet, and also fluoxetine for his expression, but as a typical vet, he did neither. That was his words, not mine, in the questionnaire. So the dog was not put on anything. There was no obvious back pain detected at this time. And over the next 2 months, the owner noticed a further increase in his depression and inactivity. So his blue funk got worse. He had an increasing reluctance to walk. He tried to bury into the ground, again, his words, hide himself during his usual weekend socialisation activities with other dogs, and sometimes indicated pain when lifted into the car after a walk. Now, there's some studies now coming out about pain in behaviour, and about up to 80%, depending on which paper you read, 80% of behaviour patients actually suffer from pain. So now with all my residents, I say the first thing we've got to do is we do a pain trial, at least concurrently, if not prior, because I do think some of these patients show these signs because they're in pain. So the dog, of course, was started on meloxicam, and a slight improvement was noted. About a month before he saw me, he was taken to a veterinary specialist due to his reluctance to walk up and down. Some knuckling and some higher back pain was diagnosed. It was thought that he had a disc problem, notice the word thought, and complete rest was recommended, and some radiographs in 2 weeks if no improvement. A dental was also recommended, and he was kept on meloxicam, but he was still depressed and uninterested in life. Now, interestingly, with Mr. Grumpy, the rest and the meloxicam solved his knuckling and other problems, but he was still depressed. So I said to the owner, I said, maybe he needs a dental. Once he had dental work done, the dog was completely fine. And sometimes we forget that the teeth are connected to the rest of it, because I don't know how often you guys have a toothache. Luckily, I don't very often, but it really does affect the rest of your behaviour. And if this dog had been suffering for a couple of months now, I'm sure his reluctance to do other things was related. And we know that dental and periodontal disease causes all sorts of other metabolic diseases. So interesting that if he'd done the dental, perhaps if he'd not been a vet, he would have done the dental earlier. But I don't know about you, I looked after my dogs when I had them, but, it took me a while to go and see people because, I'm a vet, I can treat this. And then I think, no, actually, I don't have a CT scan at home. I can't. I have to take it somewhere else. So Rodney did really well. He lived to the grand old age of about 17. So, nothing like having clean teeth and not having... makes you think about it. So Sarah is a 15-year-old female neuter Cocker Spaniel. Her presenting complaint was she had excessive vocalisation and elimination issues. Now, I never use the word inappropriate elimination. I haven't used that for 10, 15 years, and it really bugs me when people talk about inappropriate elimination. There is nothing inappropriate about elimination, okay? How many of you have eliminated today? Right? So it's an appropriate thing to do. It's the location of the elimination that's inappropriate, nothing about the elimination itself necessarily. So this dog had some issues. This is her in my consultation room. And she just was a blob. There was the only word I can say. She just was a blob that lay there the whole time. On clinical exam, she had very severe osteoarthritis. She had sensory deficits. She couldn't hear very well. She had cataracts. She had conjunctivitis. She had warts. Probably nothing unusual for a 15-year-old Cocker Spaniel at the end of the day. So the behavioural changes, sorry, I was looking at the wrong part. The owner feels the dog is unhappy. And I think if your dog laid around like that at 15, you'd probably think this dog was pretty unhappy. The constant vocalisation, I would be thinking, yep, this dog is going to be unhappy. It's probably in pain. She was antisocial. She didn't want to talk to anyone. She was restless, and she eliminated everywhere in the house, which again was really getting on the owner's nerves. The initial treatment at the GP vet was he put the dog on a citronella collar because it was barking. Now, luckily in Australia where I live, shock collars are banned. We don't have anything like that, which I think is a real good thing for the welfare of the dogs. And secondly, if this dog is in pain and is old and it can't see and it can't hear, I don't think putting a citronella or shock collar is going to make this dog better in any way whatsoever. And guess what? It didn't. The vet also put her on clomipirine, 1 milligram per kilogram twice a day. Now, 1 milligram per kilogram is not enough to work. It's a very low dose. It might be a loading dose I would start with, but most of my patients, and I don't tend to use very high doses of medications. I'm a start low and see how we go person, and most of the time they do well, but clomipramine, in my experience, is 1 milligram per kilogram. It's probably not going to help, and guess what? It didn't. And the dog was put on anti-arthritic medication, and guess what? That helped. So something for pain was going to make this dog better. So when I saw it, I put the dog on isergeline. Now, I gather you don't have it here, but it is available elsewhere, and it was available for dogs in Australia. And it is really good for, in people, it's used for Parkinson's and for Alzheimer's disease. It opens the arteries in the brain. It does a whole pile of really good stuff. And I don't know if you can get it, Barbara and I haven't been able to work it out, but if those of you who aren't from here may well find isergeline is really helpful for some of these older dogs with cognitive dysfunction. We gave it cartrophin and changed the osteoarthritic medication because although it was helping, it wasn't doing as good. And the other thing I told the owner to do was start some cleaning because urine around the house smells. Wow, that's a surprise, isn't it? But what you clean it up with might actually be making things worse. So anything that's got a bleach or a product like that in it is actually maybe going to attract the dog back to the area. So you have to use some anti-enzyme cleaners, and washing powder is the cleanest and cheapest way I can find to do that. When I saw this dog 30 days later, this is what she looked like in the consult room. So she looks like a new dog, like, oh, hello, you're here. There's somebody here. The owner said her dog was much happier, more alert, less antisocial, less restless, calmer, and she actually asked to eliminate to go out instead of just doing it everywhere. And when she did go in the house for whatever reason, she always went in the one area. So it was much easier for the owner to clean up. So again, we've made this CDS dog, and this dog did have canine cognitive dysfunction, just a happier dog in general. And, you know, dogs who live to 15 with their owners, you know that owner's pretty bonded to them. You know, the dogs who get to a year of age, they might disappear from the household because that's the most common time that people get rid of dogs because they're too hard to live with. But at 15, she really loved her dog and she really wanted to do something. So isergeline, these days I'd probably use selegiline because that is, it's not registered for use for canine cognitive dysfunction in Australia, but we can get it. But I still like isergeline and propentophyline. They're probably my first go-tos for these patients. But again, you have to have access to the medications to use them. So now I'll send you back to the person who actually... No, you can do this.
Oh, boy. Okay, well, canine cognitive dysfunction, we'll see classic changes in the sleep-wake cycle, decreased interaction with owners. There's often the first sign I tend to see with owners, or what they really recognize, is that the dog will go to the wrong side of the door. Like you open the back door and they'll like go to the wrong side. Are you with it, mate? Like, are you there? These dogs are often very anxious. And as we know, there's been quite a couple of publications that say the older you get, the more likely that you're going to get canine cognitive dysfunction. So for methods, when we're talking about CCD in these old dogs, looking at what behavior modifications we can do as the things that we can make it easier for the animal. Is it a problem with getting outside, ramps, environmental methods, as Kirsty mentioned, like if they have accidents at home, like what are we cleaning it up with? Medications, so something like selegiline, it can take a full 3 months. You can use TCAs or SSRIs, but don't use them with selegiline. And then using medications like GABA or benzos to help these dogs sleep through the night. And monitoring, of course, is important to know if your treatments are working. So that kind of brings us to the sort of conclusion. We talked about how originally neurology, psychiatry was, based on religious demonism. We talked about the breakup that happened and then how maybe we're getting back together. And I think we're going to see this continued convergence of neuro and behavioral medicine. As we have better understanding of the genetics involved in these disorders, the imaging abnormalities, there is a role for neurologists in the diagnosis, whether it be through diagnosing it or excluding other conditions, and the use of psychotropic medications, whether it be for starting therapy or for treating pain. I'd like to see improved cross-education between the two disciplines. I mean, we both focus on this little thing in here, but we don't ever talk to each other, not often enough. So I could end this presentation with a cliche, right? This is Edvard Munch's The Scream. It symbolizes his own challenges with anxiety and depression. But I wanted to show you a lesser-known work of his. This was his own Saint Bernard, and I can't help but anthropomorphize with this dog, you know, the anguish on his face. And if you look at the top brown one, you know, it just seems the fear in there. And I hope that by understanding just a little bit more about behavioral medicine, I think it'll make our own field of neurology a little stronger. So thank you very much.